For everybody, I hope everybody knows us by now. My name is Reggie Lewis, and I'm part of the Cure Violence Columbus team here in Columbus, Georgia. Also have a couple of my other teammates, Dr. Asante Hills from the health department, as well as Cedric Hill from People's Watson, Hill Watson People's Funeral Home. Um, the reason why we're here today is to really give you an opportunity to hear from our Cure Violence Global partners, Brent Decker and as well as A.T. Mitchell. Brent is the program, I guess, Chief Program Director for Cure Violence Global. A.T. Mitchell actually runs the site in East Brooklyn, New York. Um, he can tell you some very valuable information as far as when he started and some of the things that he's been exposed to as he moved forward with trying to implement or implementing that process in East Brooklyn, some of the successes that he has, but also to talk through a lot of the different things associated with what is required of this process, the type of involvement that's involved, as well as making sure you all understand exactly and what goes on with a cure violence model, and really want to make sure we get your questions answered. This is probably about a 60-minute um, presentation. We'll shorten it up a little bit so we can get to those questions. A lot of what we've given you in the past is kind of similar to what they will, but they will be able to give you a little bit more firsthand experiences with the different organizations that they work with, as well as some of the different cities that they've been involved with as well. AT has become part of their team as well, even though he does have the East Brooklyn um, sites. He works with Cure Violence Global as well because of the things that he saw and the success that he saw in East Brooklyn. So what I'm going to do is go ahead and turn it over to Brent. Um, Brent, if you look up in the top, I think it's the top right corner, you can share your presentation. It's an arrow that points up. Let me know if that'll come through for you.
I'm not seeing it. I don't know if you want to, Reggie, do you want to just share it and I
Yep.
can, that might just be easier. Thank you.
Okay.
Can I ask also, Reggie, good afternoon, or can we introduce ourselves? I need to realize or know who actually we're meeting with, if that's okay.
We good,
Okay.
yes.
Yeah, sorry about that. So I'm going to let the mayor start off. Who we're talking to today is mostly our mayor, Skip Henderson. And then we have the city council. Isaiah Hughley is city manager. And there are a couple of people I don't know. Lisa Goodwin is assistant city manager. And Mayor, I'll let you just kind of introduce yourself and kind of give AT and Brent a little synopsis about yourself.
Let me unmute. Yeah, I am Skip Henderson. I'm the mayor of Columbus, and we've had a little bit of experience with the Cure Violence Month in the past. And I think the thing that energized us as a community this go round because it was community driven. It was really being pursued by some residents, some outstanding civic leaders in this community, and they got behind it and began to have meetings that stretched. Of course, we didn't anticipate the pandemic, but it stretched over a couple of years, I think. But the city recognizes that we can change the cultural situation that we're in right now. There's way too much violence. People unable to solve conflicts without going right to the most deadly violence they can get their hands on. So we're anxious to hear from you, hear how the program has evolved, how it's changed, and how some of the successes have been born out in the community. So we're grateful for you guys spending time with us. I'm gonna turn it over to our city manager, Isaiah Hughley.
Good afternoon. I'm Isaiah Hughley. I am the city manager of Columbus, Georgia, and excited about getting together with you today. I've read about, heard a lot about this program and Cure Violence Global, and just looking forward to what you can share with us about what you've learned about Columbus, Georgia, and hopefully we can proceed forward and get some of the great results that I've seen in other communities.
Great. Thank you all for that introduction. I don't know if anyone else would like to introduce themselves? If not, we can go ahead and get started. My name is Brent Decker, and I'm the Chief Program Officer here at Cure Violence Global. I've been with the organization going on 19 years. My training's in epidemiology and public health, which we'll talk about in a minute. And it's very nice to be with you all. The ongoing conversations we've had with our partners on the ground in Columbus have been absolutely spectacular, and we're very hopeful that we can really get this to be part of the strategy in Columbus to help prevent shootings and killings. And so I'll let AT introduce himself, and then we can start with the presentation.
Yes, hi, good afternoon, all. It is indeed a pleasure to be actually here with you this afternoon. I like the great city of Columbus. My name is A.T. Mitchell. I'm talking to you live from the Big Apple here in Brooklyn, New York, where I founded a nonprofit organization called Man Up Incorporated. It's a community-based, street-based organization that deals with community issues on the ground that really depressed and deprived neighborhoods and providing meaningful services. We were founded 17 years ago after the unfortunate shooting of an 8-year-old named Deshaun Hill here in East New York. And so ever since his death, we've been born and we've been on the ground doing the work. I have been introduced to the Cure Violence model now for 12 years. And it has been the model that we have adopted not only here in East New York, Brooklyn, but throughout the city of New York. We have 35 sites now here in the city of New York, and we're very proud to say that because the results speak for itself. Thank you. Pleasure to be with you.
Great. And so to get started, and we can see on the slide, and maybe we can adjust the view on it so it's just the main slide, but if not, that's okay. So our organization was started by a physician, by a doctor, an epidemiologist who worked at the World Health Organization for many years in the 80s and 90s, and he came back to the U.S. in the mid to late 90s when we were seeing another spike of violence, kind of like we're experiencing now, and really thought about looking at violence from a health lens, from a public health perspective, and how that could be kind of a complementary way of understanding it and a complementary set of activities to work towards preventing violence. And so you can see kind of our jumping off point. I mean, really, when there's high levels of violence in a community, it's really impossible for someone to be healthy at all. You can go to the next slide, please. And what we see too in many cities, and we'll wait for the next slide to come across. Actually, homicide is the leading cause of death, especially for young people, right? And so we really think about this from a health perspective. You can go to the next slide. Next slide, please. Well, the next slide, what it's going to show you, if I'm remembering correctly. Reggie, you with me, bud? Well, anyway, we'll figure out the slide stuff in a second. But essentially, when our founder and a number of other doctors really started to look at violence from a health perspective, they really started to study it, and they saw that it not only met the dictionary, but medical dictionary definition of a contagion, right? And so they really started to think about, violence as a contagion, meaning that it causes more of itself, right? And so, that's kind of our jumping off point from the perspective. And so what we try to kind of do is move away from some of the ideas of moralism and bad people that need to be punished, and to think about this from a scientific perspective and really have this as a health problem with a health solution. So we can go to the next slide. And so, like I said before, violence, this is now kind of understood by the World Health Organization, by the Institute of Medicine, by the APHA, American Public Health Association, that violence, in fact, is a contagion. It is a contagious process. And we understand this both, on a behavioral, but also as a biological function of the brain. And so I think we're having some issues with the slides, which is okay. We can kind of keep talking it through. It's no problem. But essentially, when we understand violence as a contagion, we mean it literally, right? In that there are population characteristics, there are epidemic waves, there's clustering effects, and there's also a means of transmission. And all of this is super important to understand in terms of how do we apply what we know about epidemic control to violence and violence prevention. And so the first idea, and what you would see on the slide, and we can send a presentation, it's no problem, is that we tend to see these like hot. Okay, here we are. So are we back on here with the presentation? Go to the next slide, please. So maybe we should just turn the presentation off and we can just kind of talk this through, because I don't want this to throw us off completely. Does that make sense?
I can share the presentation if you need me to.
It would be great if we can have it, but if not, and if it's going to be, I mean, I want to respect everybody's time. I'm happy just to talk it through as well. It's okay. We can send you.
Why don't we let Rebecca Covington give it a try, okay?
Great.
Rebecca, why don't you go ahead and do that? Are you advancing it, Becca?
Can y'all see it on my screen right now?
Yes, yes.
I think we see your calendar.
Okay, yeah, that's. Hold on. I had it up and I clicked out of it because. Awesome.
You'll need to unshare and reshare, Becca.
It'll be nice when the pandemic's fully over and we don't have to do Zoom screen shares anymore. We can all meet in person. I very much look forward to that. We'll give it just a minute, and we can make up some of the time. I mean, I think what we really want to talk about now is just kind of our theoretical understanding of violence, and then how does that get applied to what we do. And so this idea of it being a contagious process, I just want to take a couple minutes to talk about it because it's very fundamental into why does this program then work. Okay, great. So if we can go down. Go to the next slide right here. That would be great. So if we look at this slide right here, what I was saying, and you have to hit it 3 times, please. Just hit advance 3 times. Well, we just keep it like this so we don't lose it again.
Yeah, sorry about that.
Yeah, no worries. And I apologize. Microsoft Teams doesn't really work well in my universe. So when we think about violence as a contagion, like I said, we mean it that there's population characteristics, there's clustering, there's epidemic waves, and there's a means of transmission, a mode of transmission. You go to the next slide. Right here, great. And so what I was saying before, like other infectious diseases, that there's a clustering effect. And so on the left-hand corner here, these are cases of cholera in Bangladesh, and you can kind of see a clustering effect. And then right next to it is my beautiful city of Chicago in violence. So you see that there's a kind of a clustering effect of the cases. Now this has to do with kind of some broader issues, but most infectious processes like have that same pattern. There are epidemic waves. It spreads in a similar pattern as things like the flu and COVID, meaning there could be no events taking place, but a couple events can happen, and then we can see this spike, and then we see it kind of follow similar epidemic waves as other infectious diseases. And the third, I think, most important part about this is that violence is transmitted, right? You can go to the next slide. And this is kind of a key thing of our understanding, is that violence is transmitted through the human brain, right? And it's transmitted through observing, through witnessing, through experiencing trauma, right? And so this is a critical thing in terms of understanding of how people and why people act violently. So if you go to the next slide, this is just a drawing of kind of brain circuits for copying. And this is true for basically all human behaviors, including violence. I think sometimes when we think about violence and violence prevention, it's like something outside of the constellation of human behaviors. And we think about it kind of sometimes through a moralistic lens, which is not always extremely helpful in terms of thinking about policy and what we do about it. And so when we think about the transmission of violence, we can go to the next slide. I think demonstrates it a little bit better than that brain circuit map, right? And so we see the boss yelling at the employee yelling at the significant other yelling at the kid, and the kid yelling at the poor cat, right? I mean, this is a very antiquated picture, but it shows kind of the process of transmission, right? And how do we pick up certain behaviors, of which violence is one of them. And so we go to the next slide. And when we think about it, we know that behaviors are formed through modeling and trial and error, and then they're maintained through culture and social norms. And Mary, you mentioned something about kind of some of the cultures around violence, right? And so we see in this picture here is we see this kid, hands clasped behind the back, following two adults in the neighborhood. It seems cute. Largely, it's an unconscious process. We go to the next slide, and we see kids the same age doing something very different, same ages, kind of just copying what they're seeing. If you go to the next slide, we see, again, children covered in tattoos, again, copying largely an unconscious process of what they're doing, right? And so this is really, for us, is critical in understanding what to do about it. So if we go to the next slide, we see that there are, many methods of exposure to violence. So there can be community violence, so this can be group, clique and gang violence, collective violence, interpersonal violence, even things like civil war or riots, things of that nature. We have media that can expose people to violence, family situations, school, even state-sanctioned violence like police violence, institutional violence, things of these nature can all expose someone. And in some cases, then that person can then perpetuate more violence, right? Victimization. So if we go to the next slide, then we see in many neighborhoods where there's a lot of violence, we see multiple exposures that lead to multiple events, that lead to multiple exposures, lead to more events. So it becomes this kind of cycle and process. And so if we can go to the next slide, and that is kind of the result in terms of how a lot of these violence kind of persists in areas, right? And that's kind of some of our understanding of it. If you go to the next slide, I mean, we also understand in health that there are social determinants of health, that range from some of the historical colonialism and things of that nature to racism to school education, things of that nature. And so, that is kind of the context in which a lot of this takes place. But we think violence has a very specific role in the social determinants of health. If you go to the next slide, what we see is, even if you think about education or economic conditions or healthcare systems or community resources or even community cohesion, like violence can affect all of those things, right? And so if you think about, even if we have, an improving school system, if kids are, highly traumatized on the weekend, then it'd be very hard for them to come back into school and concentrate, or if they're afraid to walk to school or back to school, things of that nature, or, even think about, things of community cohesion, things of that nature. I mean, violence has a very particular role in affecting all of those social determinants of health. We can go to the next slide. And for us, I mean, all of this in one sense is good news. And it's good news because we know how to stop health epidemics. I mean, it is possible to do something about it. It's complicated, it's difficult, but we know what to do. And it's really three things. So we can go to the next slide. Great. It's interrupt the transmission, prevent future spread, and change group norms. And so we do this in any epidemic control. So when I was in southern Bolivia, a long time ago, working on Chagas prevention, these were the same three things we did. What we've done at Cure Violence is really just apply this to community violence, right? And so we interrupt the transmission. We can go to the next slide. And so what the model looks like This first part is interrupting transmission, and I'm gonna have AT talk in a minute, but essentially we have a worker called interrupters, and their job is to mediate conflicts, to keep conflicts cool and prevent retaliation, so we can minimize this exposure, this back and forth of violent events. Because as we know, one violent event leads to another, right? The second, in terms of reducing the highest risk, preventing future spread, that's kind of more the long-term work with the individuals at the highest risk. And the third is kind of working to change a community and group's norms around kind of the acceptability of using violence to resolve disputes. And so I'll hand it off to AT to kind of talk about these in each more detail. But before he does, I mean, the one thing I want to say is the lane that we're in at Cure Violence is really working with those that are most at highest risk to shoot someone or be shot today, tomorrow, next month, this year, like the highest risk. Those are the closest to the issue of violence. So AT, do you want to just talk a little bit
Yeah.
about the components?
Thank you, Brent. And so with that understanding of our approach, which is, if you can go to the next slide, please. Our goal is to get to those members who Brent just described, those that are the most highest risk members of the community. And we do that by bringing in a very qualified, very special group of individuals that we call violence interrupters, to interrupt the transmission. These are men and women who are credible members of the community that live in the neighborhood, was familiar with the issues going on in the neighborhood, but they have a will to want to assist in us trying to curb the violence and reduce a lot of the trauma that is happening. The violence interrupter is people who have been there and done that type of individuals. People who may have been shot in the past, may have been had trouble with the law, maybe had have access to a weapon in the past, but now they are thinking about using themselves in a very positive light. So what we actually realize is that those that are closest to the problem are the best ones to be help us with the solution. And so we go out and we literally canvas and we look for these individuals in the neighborhoods where the violence is most prone, and we make contact with them and we ask them to come in, and we interview them to see in fact if they're serious about wanting to help us curb the violence. And if they are, we'll go through a process of screenings, and these individuals are eventually hired by an entity, a partner organization on the ground. And they are literally trained in the Cure Violence Global model. And then they're deployed right back into their own neighborhoods. Now they're more advanced, they're more educated, they're more trained to know how to engage their own kind of people in the neighborhood, to get to that most highest risk, and to begin the process of building trust and to mediate the conflicts that may arise as a result of it, of some potential violence that may be about to happen. Can you go to the next slide, please? And so these credible messengers that we call are credible because these people have backgrounds that the neighborhood respect. The people in that lifestyle respect these individuals because of their credibility. These people are those people that we literally ask to work with that population. And we have another type of person that's credible in the team. They're called the outreach worker. So their job is to go out and to manage a caseload of 15 high-risk individuals and to begin to work with them on a day-to-day basis to find out what are some of their needs, to find out what are some of their wants, and to see if we together can work to get the needs to these individuals and their loved ones, to hopefully get them to agree to exchange the resources and the opportunities that are made available in exchange for peace, for peaceful days, to help us get in front of the problem, not necessarily respond once a shooting happened, although we're trained in that as well. A lot of the work that the outreach worker and the violence interrupter do is actually in the beginning. It's in the proactive stage. And so these outreach workers and these credible messengers are deployed throughout the day during the same hours that population is out there as well. And they work to pretty much be in their peripheral, to stay in their peripheral, almost like the police, but for a different intent, right? So they are going after the same individuals. Their intentions are different. Our goal is to get to them before they commit a crime. and if we can help them help themselves and convince them to ultimately change their ways and their behaviors, then it's a win-win for everybody. Next slide. Because this is all about changing behaviors, right? We know that these behaviors, in terms of violent behavior, gun violent behavior, is something that have been taught. This is not something that they were born to do. As mentioned before, these are things that they pick up based on the exposure that they have been experiencing and the way that they've been reared to assume that by handling a sometimes interpersonal dispute with going to get a weapon and discharging a weapon on another person is not actually normal. Individuals know that they need to change their behaviors. The actual employees are real examples of change agents. And so they are the ones that are mimicking that change behavior, similar to like what we saw in the earlier slides with the children following behind their older people in their communities. And so if we put something different in front of them, a different role model or different real model, then more than likely it will be contagious as well. And that new behavior norm will begin to be applied, and hopefully we'll be able to see a change in the entire community in terms of how the trauma that they have been exposed to. So these are folks that actually know how to go in, they know how to problem solve, they know how to avoid situations. They're very familiar with the terrain. They're very familiar with the neighborhoods. They have more access than any of us as it relates to their neighborhoods inside, let's say, the troubled areas of Columbus. These individuals are people who know the people on the ground, and they literally, because of their credibility, they're entrusted to help mediate conflicts. And so they're trained in conflict mediation, they're trained in conflict resolution, they're trained in motivational interviewing, and all of the above. They know how to, manage caseloads. They're trained to know how to enter data into the database, and everything is all documented. And so this is how we use these individuals in the community to help us change the outcome of what's happening in the community. Next slide. And so ultimately, this is about getting the whole community involved. Unfortunately, because this violence has plagued communities for so long, most neighborhoods, when we come in, have been desensitized to the violence. They begin to start accepting the violence as a norm, and it actually is not normal. And a part of the way that we think of it as a disease and the approach that we use is that we make sure that every time there's a shooting, there is a community response, right? The messengers, the credible messengers, and the outreach workers and our stakeholders and partners, we come together and we mobilize the community around the issue of violence as an abnormal behavior. And literally we send them out there and to the neighborhoods, and they're where the shooting incidences occur. They're sometimes in the hot spots. They're doing all kinds of community events and community activities. But more importantly, we're making sure that the norm in terms of the way that we see violence as we know it is no longer. And we begin to change the perception of violence and the disease. The idea is to stop the disease in its tracks. Next, Norm. Next slide. Excuse me. And so you may have seen some of these happen organically in communities after a shooting. The local, clergy, the active clergy, and some of the activists on the ground will organize these vigils. And so this is something that we do regularly. We have actually circles like this, maybe what we call a healing circle in the streets, in the heart of the troubled areas, where we're praying and we're talking to the community. We're raising up, the name of someone who may have gotten shot and killed, and we're introducing them to the new norm as it relates to us as a community, as to how we begin to address it through these visuals that you see here. So this is something that we promote. This is something that we train the staff on how to go out into the community and how to mobilize community around every single shooting that may erupt, and how do we get in front of it instead of trying to come behind it. So that's pretty much our approach, and it's been working everywhere across the country, if not throughout the world, when we see the model being replicated. Next slide. So we use a host of different methods. We pour a lot of pub ed campaigns into it. Here you have an example of a lot of the literature, a lot of the statements, a lot of the postering that goes into those neighborhoods. We begin to mask the neighborhood in a different way versus it being labeled with advertising from cigarettes and alcohol. We actually literally like to uh, uh, plaster neighborhoods with this messaging so that everybody actually that is inside that neighborhood, around that neighborhood, receive this messaging on a daily basis. They're given, they receive these in the form of palm cards, in the form of brochures, in the form, like I said, of posters. The businesses get involved. Everybody gets involved in helping us promote this new messaging. As you see here, these are samples that we've used over the years throughout the country. And it makes a big difference. When people begin to start seeing different and knowing different, they begin to do different. Next slide, I'll turn it back over to Brent.
Yeah, and so what this kind of approach does, I mean, I think if we understand how behaviors are formed, how they're maintained, ultimately they're changed by what AT was just, outlined. And I think the key point is this idea of having credible messengers, and this what really helps folks change their thinking around the behavior. Right? They're not going to listen to me. You know what I mean? I'm from Chicago. I'm not from that community, and so really the three prongs of the intervention are really kind of based on how do humans really change their behaviors, right? And it also kind of asks us to re-understand violence, right? So that to kind of move away from some of this idea of like bad people and even bad choices, and really to understand kind of the circumstances and this issue of transmission, and having science kind of lead the way in terms of some of our policies. We can go to the next slide. These are the cities that we're currently working with in the U.S. And the way that this program works is we always work with local partners. So Cure Violence doesn't open up offices anywhere, right? Our offices are run by local partners that are usually managed through a city, state, or county kind of apparatus, if that makes any sense. That's like the oversight of it. That then do the direct implementation through community-based partners. So in each one of these cities, there's different kind of partners involved in it. So this is to give you a sense of the cities we're working in. You go to the next slide. This will give you a sense of like the countries that we're working in. And so a lot in the US and Latin America, and some Caribbean. We've done some work in Africa. We've done a bunch of work in the Middle East. And again, it's always doing the three things: interrupt transmission, prevent future spread, and change community and group norms. It looks different, though. It looks different in Baltimore than it does in Trinidad, than it does in South Africa, but it's the same thing: the credible messengers reaching out to the highest risk to prevent violence. And so what happened, if you can go to the next slide, the reason that I'm even talking to you all this afternoon is when we first started a long time ago in Chicago, what we started to see was the areas that were doing the program, and it was called Ceasefire at the time, were experiencing greater reductions than comparison areas, neighboring areas, or Chicago as a whole. And then we looked at it again, if you go to the next slide, in 2005, what we saw is that in our areas, in fact, we're experiencing reductions. The comparison areas a little bit, neighboring was going up, and Chicago in itself was going up. And so this really caught the attention of the Department of Justice and other institutions, and a number of independent evaluations were done. If you can go to the next slide. Go to the next one again, please. Thank you. And so the first evaluation was done by Northwestern University, funded by the Department of Justice. And it looked at a couple things going on in Chicago. One of the main findings it had was this idea of cooling hotspots down. So you can see on the slide kind of before and after, this idea of cooling down shootings per square mile, right? So we're cutting down the exposure, we're cutting down the trauma, we're cutting down all those things. And what you see in it is if we work with the highest risk, it's not about pushing it somewhere else, right? It's about cooling it down in the areas that we're working. You can go to the next slide to look at another example of that. This is Inglewood. This is the south side of Chicago. Again, before and after the intervention, we see this cooling down effect. So there's less shootings, less homicides taking place. And it's not just being like pushed somewhere else because we're working with the highest risk. You go to the next slide. Some of the other findings they saw, shootings went down, hotspots went down, but I think that was very interesting about that initial evaluation was this idea of retaliations. And in some neighborhoods, uh, because of the partners and because of the relationships they had, they were able to reduce retaliatory homicides by 100%, right? And so this is a critical piece. If we can stop this back and forth, and if we have the right workers, this is something this is possible. So these were some of the findings of the initial program in Chicago. If we go to the next slide, the next evaluation was done by John Hopkins with, again, funding from the Justice Department, looking at the program in Baltimore. And so what we've seen in Baltimore, reductions between 33 and 47%. What's interesting though is Cherry Hill has gone, which is a housing project in Baltimore. It's kind of one street in and one street out, has done multiple years without a homicide. And last year, they actually just a couple weeks ago completed another full year through the pandemic without a homicide taking place in their area. And again, that's because who the workers are. It's based out of a local community organization. The oversight agency is the mayor's office of criminal justice, like it is in New York, but the work on the ground is done by local community partners. And so that was some of the findings in Baltimore. We can go to the next slide, please. New York City, as AT said, which is basically the biggest replication site in the world. Multiple sites, multiple years. It's part of the yearly budget. What we saw there too is, and this was done by John Jay College, funded by the Robert Wood Johnson Foundation. And again, they saw gun injuries going down, shooting victimizations going down. Again, all statistically significant. We can go to the next slide. And what we saw is the areas that we were working in, and by we, I mean our partners, we saw greater reductions compared to comparison areas. And so another finding that was interesting in the John Jay evaluation is that actually community trust in police went up in the areas that we were, confidence in police went up in the areas we were working in. And that's not necessarily a stated objective of ours, but being kind of community and health centered, when we can reduce this constant back and forth of shootings and killings and responding, it really can allow some other spaces for other conversations and other types of engagements to go. So we can go to the next slide. Another evaluation, and I'm going through this quickly, this is all on our website, but all this to say that when this program has been evaluated, it's been shown to work in a lot of contexts. So Chicago, Baltimore, New York, also in Trinidad in the Caribbean. You can go to the next slide. I mean, what we've seen there is we were able to implement it successfully. We were able to see, reductions in shootings as well as admissions to the hospital from shootings. You can go to the next slide. I think it demonstrates it a little bit better. But what we see here is when the program launches, you can see this immediate decrease in terms of serious violent incidents. And it goes back up just a little bit, but it stays lower, by like 60% or something like that for the course of the program. And even after the program ran out of funding, maintained these reductions because it was really about the norm change, right? It was really about working with the highest risk so that just because I'm in conflict with someone doesn't mean I necessarily need to go get a gun to resolve it, right? So you can go to the next slide. This is just another demonstration of that. And what we see, though, is in our areas, it went down. And in the control unit, it continued to spike up, right? And so this is a really critical piece in terms of our understanding and really showing that this intervention worked in the context of Trinidad, which at the time was the most violent city in the Caribbean. I mean, people often think of Jamaica, but Eastport of Spain had much higher rates than even Jamaica did. You can go to the next slide. And the last evaluation that's been done, which was released in December of last year, funded by the Inter-American Development Bank, was about our program in Cali, Colombia. And Cali at the time was the most violent city in Colombia that has, historically been one of the more violent countries on earth. And we were working in 2 of the top 10 most violent communities. And what we saw in the first intervention area in Charco Azul is there was a reduction of almost 50% in homicides and almost 50% reduction in retaliations, right? And so what we saw in Colombia is there'd be a homicide, Within 7 days, there for sure would be another one. And so they're able to reduce that, not only the homicides, but the retaliations. In Comuneros, which is the second area, which was the most violent place, I mean, we first went there, I couldn't even go inside. We saw reductions of 30% of homicides, and then we also saw a complete wiping out of retaliatory homicides within 7 days. And so these two neighborhoods that were on the top 10 list of violent areas in Colombia are now off that top 10 list, and we're now working with the government there to do a whole citywide intervention. I don't know if you might have paid attention in the news. Cali was one of the cities that had a lot of violence with some protests about a month ago. And so they're working to kind of respond to all of that. We can go to the next slide. These are just some examples of other cities that have done some demonstrated results. You can go to the next slide. I want to make sure we have enough time for conversation about this. So, you know, we've seen success in Cape Town, Halifax, Puerto Rico, the UK. Next slide. Many communities, including ATs, have gone a year, 1,000 days without a homicide, you know, in doing this approach. AT, I don't know if there's anything you want to add about that before I go to the next slide.
No, go right ahead, Brent.
Yeah, okay, great. Go to the next slide, please. You know, essentially, this has been featured in the Interrupters, the Institute of Medicine. Nicholas Kristof has written pretty extensively about it. But if we go to the next slide, this whole idea of a new city assessment process, it's a kind of a collaboration. So next slide, please. So we've been working locally with the Cure Violence team to really figure out, answer these questions, right? Is there governmental or non-governmental agency with the capacity and will to do this model? Are there official data sets so that we could focus, monitor, and measure the implementation? Is there enough data to determine, like, is the violence taking place in Columbus like appropriate for our approach, right? So if it's all domestic violence, or if it's all terrorism, or if it's all, you know, cartel ordered hits, this model is not necessarily applicable. But if it's more general community violence, interpersonal dispute that take place kind of in a context of the drug trade and other things, you know, there's a lot of different elements that might contribute, but as long as it's in that realm, this model can be applicable and helpful to reducing. Go to the next slide. You know, again, thinking about, is there a criteria to really understand the highest risk? Do organizations exist that can implement this? Are there individuals who can serve as interrupters and outreach workers like we described? And then we try and determine, like, what would some initial program recommendations might be, so that if, you know, we move forward with this, we have a very clear plan, like, these are the areas we would work in, here's some of the community groups, or here's some of the recruitment strategy that would be required to do it. If you go to the next slide, you know, and these are kind of the phases. And so where we are right now is kind of in, you know, into phase 2. I mean, we've done a number of Cure Violence 101 presentations, you know, just trying to kind of share what the approach is. Then we'll move into more kind of stakeholder meetings. Then we'll do a visit at some point this summer, and then finish up with what the budget and plan would look like, so how this could be helpful to what's going on in Columbus. So I will stop right there. AT, is there anything you wanted to add that I kind of missed out? I wanted to make up for a little bit of time.
No, and I appreciate that. And for the sake of time, I'll just wait to hear the questions and see how we can better answer any questions they may have.
So anyway, we wanted to open it up to allow, you know, any questions or concerns or comments about the approach, some of the results, or kind of where we're at with it. So thank you very much.
Can I stop sharing?
Yes, please.
Okay.
Yeah, just, Brent, thank you. This is yep. Just a quick question. Identifying the interrupters. I would imagine that's, if not the most critical, one of the most critical pieces of this, to make sure you get the right personality, the right credibility when these folks go in those areas. Typically, what is the timeline for being able to identify, assess, interview, and hire the right individuals?
Mm-hmm. So the process kind of entails a couple steps, right? I mean, I think the first thing is, once we know what the areas are going to be, then we kind of map out what are the community groups we know, and we kind of get the word out, like, this is what we're looking for. And this can take, you know, a couple weeks. And what we typically do is we have kind of like an informal presentation of other interrupters or staff like AT who's managed sites, to kind of just really talk through like what it is, what the approach is, and what the role is. And then from there, we usually find a couple people who meet the criteria and are interested. And then we kind of do something called the pre screening, right? Where we really want to look at those individuals, make sure A, that they're credible in the areas that we're going to be working, but B, are they suitable to do this work? Just because you're credible doesn't mean you're necessarily suitable to do this work. And when I say suitable, it's really about being part of a team, really being on this side of the line, if that makes sense, having other kind of positive things going on in your life, strong relationships. And once they kind of go through that, then we have a hiring panel process. And the hiring panel process is we invite people from law enforcement, partners, faith leaders, and we make kind of a group decision. Like, does this person really make the most sense to fulfill this role? Once they go through that, they go through an initial 40-hour trainings, and then they're ready to hit the streets. So this can take place between 6 weeks, 8 weeks. It just kind of depends on the flexibility of people's scheduling and things of that nature. So Charlotte, for example, we did in Charlotte, North Carolina, we did panels for the managers 2 weeks ago. They're getting trained next week. AT&T are training them. They're going to have their violence interrupters and outreach workers. They got paneled this week. They're getting trained in 2 weeks, so they'll be ready. They'll be starting, within 8 weeks of the program really launching. So, I mean, I think it depends. Sometimes it goes quicker, sometimes a little slower. But you're right, Mayor. Like, that's the critical piece: is getting the right workers, getting the staff that are really committed to do this work, doing our background checks on them to make sure they're really ready to do this, and then training them fully to do implementation.
And if I can add to that, Mayor, and this time that Brent just talked about is very critical, right? Because what we want to make sure is that, like, they're not only credible, but they are suitable, because we want to put them back out there. That we have to make sure that they're prepared and understand exactly what they're getting themselves into. This is very dangerous work because they are going out there on the front line and they're going to be working in the trenches. And so, their lives are in our hands, and we want to make sure that they are very confident about their role and how they're going to go into these neighborhoods and make a difference. And so we really speak, like, we spend a lot of time on just making sure that they're trained, they're tested, and that they're ready to go out there, so that when we do deploy that team, we feel confident that they are a very competent team that knows how to apply the model and to make it back in at the end of every shift.
Thank you, AT. What another question I just popped in my head. What y'all are all over the world now, and as I mentioned before, we had actually had an opportunity to hear some of the uh, um, information on cure violence about 9 years ago, I guess 9 or 10 years ago. And I think one of the things at that time we had heard was that our community is not a small community, but it was smaller than most of the cities that y'all were operating in already. Have you found that there's a threshold of effectiveness in terms of the size or the density of the population?
So what it is, we think about it in terms of like the intervention space unit. And so it's not necessarily always like how big a city is.
Right.
I think it has to do with like what is the rate and the numbers in a specific area. And so if there's only 1 or 2 homicides a year, that's a hard number to move, if that makes any sense.
We're just a tad above that. We could probably be
Yeah,
moved.
and looking at the number, I mean, I feel like you all are having, definitely above a national average in terms of events. And so I think if there's an area that has multiple events over the course of a year, right, in terms of like homicides, and then, sometimes 5 times as many shootings, or it just kind of depends on what the ratio is. And so that's how we kind of think about it. Now, if there's in a city and there's not the clustering effect, and it's like a citywide thing and it's more random acts, then that doesn't work. But if there are the kind of pockets and clustering within the city, we think about it at kind of that community unit. And that's, we've been successful in Halifax, Canada, which, people were surprised that there was violence there to begin with. But, it had not a ton of homicides, but it had a lot of shootings. And so, and it was, geographic clusters of it. And so we were able to kind of work at those clusters levels.
All right, thank you.
Yep.
I think Counselor House has a question. Counselor House, if you could unmute yourself.
Thank you. Yes, I'm Counselor John House. I'm one of the at-large counselors. Based on your experience, is there a projected amount of time that the program should continue in order to actually affect the norms so that the change is permanent?
Yeah, and I'll let AT, but the way we think about this is best case scenario, this becomes part of a city's strategy long term, right? In that it's not just like a pilot program, but it's really part of a way that a city does business. And I think what we tend to see is we can see drops happen in the first year. We usually see between 40 and 60% that first year. Then some of the long-term work with some of the behavior change takes in a couple additional years. And what we've seen cities do is it becomes part of their strategy. The investment can go up and down kind of depending on how many areas or what the clustering is. But we think the best thing, like you would with any immunization plan or anything like that, is you have it kind of follow what the epidemic wave might be, but it's part of a strategy.
Okay, all right, thank you.
Yep.
I wanted to add to that in reference to the timeline. You know, when you really dive into and you look at the historical context, like in terms of how long folks have been really dealing with these issues, these kind of like socioeconomic, kind of issues that contribute to the, poverty and things of that nature. A lot of times what happens is, when they are working their way out of that issue, it may take, if not equivalent amount of time, but more, right, just to recover from it. And so when we do see, like Brent mentioned, some immediate results, and maybe even some sustainable results, it is something that we'd like to think that it becomes a permanent part of the way the city does business. I can tell you here in New York, we're going on 12 years, of applying this model, since we was introduced to it back in 2009 and 10. And so, and we have every intentions. I know our administration has gone on record as saying that this is something that we're looking to make permanent, because we really want to get it to the day, and I'm sure you as well in Columbus, where there is a 0 reported homicide, for the year, right? And that's ultimately the collective goal. And so the more I think that you have these type of men and women involved in the success of it all, the better it is for the overall city.
This is Gary Allen. I'm one of the city councilors. I have a follow-up question to Councilor House. Once the interrupters are identified, do you use the same interrupters throughout the term, or are you cultivating other interrupters to work with them along this timeline? And then how long do you think that timeline is, or what is the average?
So the average life, let's say, or the history that we see is that folks come in and work an average between 3 to 5 years. And so, that's something that we do know that going a transformation themselves as well. And so, as mentioned, our goal is to not only, just to grow them, to make it so that they do, model the new behavior, and they actually encourage others to get involved. And we see that happening on a regular basis, where folks who were a participant on someone's caseload is someone that is seriously considered to become a member of the actual team. And so there is a lot of that's happening across the country, where individuals are coming in and they're starting off as outreach workers and or violence interrupters, and then they're moving around inside the entity. They maybe move on. Some of them become part of the supervisory role, the administrative role. Some even grow to even start their own sites. And so, yeah, it is something that it does really do create a pathway for employment for other individuals in the neighborhood. So it's averaging between 3 to 5 years.
Thank you.
one more question.
No, please.
Y'all are in the midst of your analysis right now, I guess.
Yep.
Typically, how long does that take?
I think we should be done with it shortly. I mean, there's the things, the answers, in terms of like the positioning, the data, I think all that's there. What we really want to get to in the next couple weeks is, really honing in, and some work has been done on what the specific areas are. And then from that, what would be a recruitment strategy for the workers? And so we're hoping to have that done shortly. Those are kind of the next steps. The team we're working with there are super responsive. The ones who are slow is me and AT, because we're all over the time. But I think from our conversation so far and everything we've seen, it seems very feasible to do. I think we just have to land on a couple things over the course of the next couple weeks, and then I think we'd be ready to making some moves forward. So short term for sure. And again, that really has to do with our partners on the ground just being super persistent and very methodical in terms of the data gathering and who they've convened as a group and as kind of stakeholders. I would say, and I've been doing this for a long time, has been the most organized ever. And we're very pleased to be in this partnership and are taking it very seriously. So we're very happy to be working with them.
Very good. Thank you.
So, Mayor, I hope y'all can hear me now. I was having issues. Sorry about that. One of the things we're working on, Mayor, as Brent said, is to really start focusing on the areas. I mean, we have an idea. The data that we've collected showed some anomalies, not anomalies per se as bad, but we had a higher average age range when it came to offenders and victims, of almost an average of 30.9 was the average age for most of the events across robberies, assaults, and as well as murders. Definitely Black males is the highest population that we've seen across, which we kind of had an idea that was the case. So the last piece is really for us to focus in on making sure the areas that we identified initially, that data supports that, and ensure that we are working with the hospital to get some data from them as far as what they're seeing coming through the hospital, just in case it wasn't reported to the police. But those numbers seem to be still seem to be in line with what the police have as far as assaults. But there's some other data in there that we're trying to track as well. So we're pulling data from everybody. We've gotten it from enrichment services that provided a lot dealing with poverty, homelessness, education, and some other things that help out as well. But as well as from the hospital that told us the different assaults that can come across: domestic violence, rape, stabbings, and gunshot wounds. We were able to really get some ideas of what we're seeing even in the pandemic, but we're trying to go farther back to see what we have from a trending in 5 years. And that's coming along pretty quickly. And hopefully we can get the data that helps us identify the hot spots and confirms that very quickly. And like Brent said, we'll start moving forward. We're trying to get them down here, and then moving forward, trying to come back with an implementation plan so that people can hear it all.
Okay.
Were there any other questions y'all had for us, Mayor, or the council that we can answer?
Not from me. Mr. Hughley, you're on mute.
Thank you, Mayor. I was just saying I don't have any questions at this time.
Reggie, I think it would probably be great if you would just kind of sort of give a little bit of an update of some of the people that we've been meeting with of late, because we've kind of sort of had a great session with some people that we think will be a great beginning process to initial interruptions. We kind of sort of cover that. That would be great.
Yeah, we've been very fortunate. We were able to meet with some of what we consider to be the interrupters in our community. Several different folks. We had several that were convicted felons that have turned their life around, opened businesses in Columbus. But the amazing thing that we were dealing with on Monday, we sat down with Piedmont Hospital and their trauma nurses and their trauma staff, Pastoral Institute for Mental Health, East Carver Heights organization, community-based organization, and then, like I said, 5 or 4 community-based activists. One gentleman, we call him Tarhead, 5-time convicted felon. He was the one that had the caskets out at the Spiderweb on a Saturday, had them displayed across Buena Vista Road so that people can, come out and they talk serious business about, if you don't change your life, you're being these caskets. Jerome Lawson was a very, I want to say very unique situation in that he was arrested at 16 for armed robbery. His father basically told him, not to do it, but basically don't get caught. And because you're 16, you don't have to worry about going to prison. Well, unfortunately, he committed armed robbery and was caught. And basically his dad couldn't get him. They sent him off to prison for 10 years. While in prison, he basically saw himself and basically said he wanted to come out of prison and open his own business and start a food truck. And that's what he's done in the community. But the biggest thing that he talked about was really sitting down and being able to talk across all the different social and economic backgrounds, black, white, whatever. It was going to take all of us to be able to change what's going on in the community. And it was an opportunity for us to listen to one another, but also to have a better understanding of what's happening on both sides. And that Monday, we had people from the hospital. Jessica Carden is the case manager, trauma worker. And she was talking about how she had a young man, the video that we saw on Facebook Live, one of the gentlemen, the gentleman that was killed was actually been through the hospital 3 times prior. And she was talking about how she was trying to engage him to reduce the risk that he was involved in. And the problem was they saw her as a white woman and she couldn't understand what they were dealing with. But she was trying to explain that everybody in that trauma center cares about them as humans, not because of their color, but simply as humans. And so those guys got to hear that. They invited her to come to, their areas, their neighborhoods to talk about that. And what we saw was a collaboration across different platforms and different folks. And so we have a good basis. And afterwards, we asked, did everybody want to be involved? We had about 25 people in the room, and every single one of them raised a hand. So we're getting started with, the different violence interrupters and outreach workers. That was a major start because we were able to really talk in depth about the struggles in the community. And also we have other folks out in the streets like Norman Quarles that are bringing us several interrupters as well. So we're starting to build that basis and the folks that we need to be that outreach worker and as well as that interrupter. But the biggest part is creating that relationship between the community and the hospital is a big piece of it as well. So I guess if nobody else has any questions, like we said, the next steps is for us to continue with this process. We'll probably have 1 or 2 more one-on-one workshops to ensure that we've got a lot of people involved in it and able to see the presentation, but also ask questions. As you know, there have been still a lot of questions from the community on the process. And I know it's a difficult process to understand because we do want to have a tendency to look at things as a moral issue rather than to understand what has caused the issue from either adverse childhood experience or adverse community experience. So we want to have at least 1 or 2 more just to kind of give the citizens an opportunity to hear it and to ask questions and really move forward from there to really get to the on-site visits.
And Reggie, I know we're kind of at 4 o'clock, but Andrea Dorbu, who is our intern here at the health department working on cure violence with us, she does have some data. If there's time, Skip, if they're at the end for her to share some of that, we could do that pretty quickly as well. She's prepared to share her screen.
Yeah, that's fine. Anybody that has to drop off can, but I think that'd be good information.
Okay. Hi, everyone. It's great meeting y'all. Let me go ahead and share my screen. Okay. Can everyone see my screen?
Yes, ma'am.
Okay, that's great. So, as Mr. Lewis said, the primary target population are Black males. In terms of victims, they comprise of 61.18% of all victims of robberies, rape, and aggravated assault incidents from 2016 to 2021. And in 2021, it's just January and February 2021 that we have the data for so far. And then the mean age of Black male victims was 30.9, and then the mean age of Black male offenders was 28.1. That being said, those numbers do look very high in comparison to what I have listed up there as the target population, age range between 15 and 24. And that is mostly because when we're looking at a large data set, we have outliers. So, of course, some of the age ranges for offenders and victims were 40 years old and 50. So that's why the data, the mean ages look a lot higher. But that being said, the most common ages that we did see in the data set were 16, 18, 22, 23, and then 24, which falls in line with the target population. And then for crimes in which Black males were victims and offenders,
Andrea, you're frozen on my screen. I don't know if others can.
Yeah, on mine as well.
Yeah.
comprised of 17.02% active and
We can't understand you. You're frozen.
earlier.
And she probably can't hear us because she probably has a delay on her side. Okay.
Time for this. Okay. Stop sharing options. Can you all still see my screen? I'm sorry, I dropped off a little bit here.
Yeah, we can.
Yeah, we can.
Stop share. Can you all hear me?
Yes, we can hear you still. Nope, just a little bit.
Yeah, sorry about that. So stabbings comprised 0.4%, and then gunshot wounds were 16.8%, and then other crimes were 9% of all the trauma victims that they saw at Piedmont Columbus Regional between 2020 and then early 2020. And that's just a brief overview of the data. I can send this to you all, and it has more detailed information about the trends between each individual crime that was pulled from the Columbus Police Department.
I think that'd be good.
Thank you, Andrew.
Yeah.
Well, Mary, so Mayor, that's in City Council, that's basically what, when we were talking about analysis and data and things like that, that's what we were trying to do and trying to really pull out, because it gives us more of a pinpoint of where we need to focus in on, and not simply just say, okay, let's try an implementation. You know, we need to be very focused on the groups and understand why those numbers are like that, and ensure that we stay focused on the right group, and not simply just throw something in place that's not going to work because we're not attacking the real issue. So, like I said, we have a couple more data points that we need to pull, but just kind of want to give you an idea. And what we'll send over is really our strategic plan that kind of covers high levels what Brent and AT went through, but also the data that Andrea presented to you today. All right.
Reggie,
So-
thank you. Brent, AT, thank y'all for sharing your time with us.
Likewise, thank you, Mayor, as well.
For your
Appreciate
time.
Well,
All right,
guys,
Reggie,
that's,
we'll just wait
that's
to
all
hear
we
from
have.
you on the follow-up.
Great.
Okay, we'll do.
All right, thank y'all. Good job.
Thank y'all. Bye.
Thanks, Reg. All right, all.
Thanks, everybody.